Good morning, everyone. A very good morning. Welcome on a Sunday morning. And also, thank you for making us a part of your Sunday breakfast and chai. So, this is the ninth case discussion we have in place today. So, again, uh, a warm welcome to the community who has showed up on a Sunday morning, and a very big thank you for being here. That your simple presence, your questions, your discussions are an extreme motivation to go ahead with this case discussion series. As more and more speakers are coming ahead, we want to share your pride and joy. So, happy Dasera for those of us who had the celebration yesterday, and Shubhu Bijoya for all those whose celebrations are still ongoing today. So, with that, we start off. Thank you for being here. So, our speaker for today is Moumita Hati. I'll just quickly introduce her. She holds a bachelor's in audiology and speech language pathology from Mumbai. She holds a master's in speech language pathology from Ohio University. She has a certificate of clinical competence of speech and language pathology from the USA. She is a speech language pathologist and swallow therapist here in Mumbai. She is the team leader at PHE Clinic Mumbai. She has one publication. She specializes in adult swallow disorders, pediatric feeding and swallow disorders, and adult neurological speech and language disorders. She is certified in oral placement therapy and the SOFI method of infant feeding and a certified brain injury specialist. So, with that, I'll stop sharing and I request you to start sharing the screen. Welcome, Moumita. I hope you have a good time with the case discussion over here.
Language disorder. All right. Just give me 1 second. So let me talk about my lovely patient. We name him KM. So he's 50 years of old, and on 24th of January, he came to the ER with headache, difficulty with speech, and right side paralysis. He didn't have paralysis yet. So he was diagnosed with a stroke. So the CT scan revealed left parieto-occipital infarct. So he was given thrombolysis, followed which he had a hemorrhagic transformation. So it started off as a very simple embolic stroke, but then it digressed to more bigger areas. So his CT scan just showed left of parieto-occipital infarct. But after the thrombolysis, we repeated the CT scan after a day, and he demonstrated left MCA and PCA acute infarct. And also, he had an episode of focal seizure on the 12th day. So he had a lot of secretions, and his swallow was not great. So after 4 days, they did a tracheostomy. So he was intubated till then, but they couldn't manage the secretions. So they did a tracheostomy on 28th one. So to begin with, we got a reference in the hospital itself, in the ICU itself. So first, when I get a reference for a speech language or swallow therapy, and the patient has tracheostomy, I first focus on the tracheostomy part, because once the tracheostomy is there, I can't do speech because the patient is unable to voice. I will explain to you why. And also dysphagia, starting with dysphagia, it's better to work on the tracheostomy first. So first thing that I did was, I'll just quickly explain what a tracheostomy is. So basically, a tracheostomy is a tube. Yeah, it's a tube right over here. There's an incision done, and the tube is inserted. So basically, the tube is used for two reasons. A tracheostomy tube, either for breathing purpose or for managing secretions. All right. So basically, a tracheostomy tube this white part is inserted in the trachea, and there's a cuff which holds the trachea in its place. Holds the tube in the trachea in its place. So the cuff can be used for two reasons: either to hold the cuff in the place, and also it prevents the secretions from going down into the lungs immediately. And and most of them have a suction tube, like a supra cuff suction tube, which helps to remove the secretions when it goes there. Right. So the first thing that I always start with is cuff deflation. So here you can see this is the mouth. The tracheostomy tube is in place. The tracheostomy tube is in place. This is the cuff, this little thing. And now we are going to demonstrate how we can remove the air. So with a syringe, we place it in the cuff, right, and we pull out the air. So you see the cuff is deflating, and the passage from the lungs to the larynx, through the larynx and to the nasal and oral cavity is um, open. So here, typically, before you deflate the cuff, we have to orally suction the patient. We have to do tracheal suction and also remove the secretions from the yeah, from the supra cuff area. Right. My patient typically tolerated the cuff deflation after 2 or 3 trials. Suddenly, the air starts going through the nasal passage and the oral gases. So, patient normally starts coughing. Don't be alarmed. That's a normal thing to do. Normal thing to happen. Right. So once the patient was comfortable with cuff deflation, what I did was I did a digital occlusion. So basically, digital occlusion is you take your finger and you cover the tracheostomy tube opening. It's very simple. It's just gloved finger and you just put the occlusion. Okay. Now, why this is important? Because before we start anything, before we put the speaking valve, we want to see whether they are able to tolerate it. We have to check for the SpO2 level. The oxygen is not dropping. We have to check if there's any breathlessness, any increased cough. So here, what I did was I physically occluded the opening and asked the patient to vocalize. So because of the stroke, he was not able to vocalize. He was able to say a little bit, but not e, oo, or oo. After 2 days, we put in a speaking valve. Now, what is a speaking valve? It's a one-way valve that we put on the tracheostomy tube. So here what happens is the patient inhales from the tracheostomy tube. But because the cuff is deflated, the air goes from the lungs to the trachea, to the larynx, and able to voice. So it is half normal. Now you understand the importance of cuff deflation. So you cannot put in the speaking valve with cuff inflated. Because if the cuff is inflated, the air will not be able to go up. The air will not be able to come out of the tracheostomy tube. Okay. So here the patient will choke and have breathing issues. So we deflate the cuff, we put in the speaking valve, and encourage the patient to talk. Okay. Now, I prefer putting a speaking valve even for dysphagia therapy because it is half normal first. So there's a sensation to the pharyngeal area, oral area, nasal area. We all know that these play a very important role for dysphagia too. The patient has to feel it, smell it, and then the swallow becomes faster and better. So it's very important to put the speaking valve before we do before we do language or dysphagia therapy. Right? So I'll start with the dysphagia therapy that we did. First, I did a cranial nerve examination. So basically, here we listen to the patient. So we pay attention to hoarseness or nasal quality of speech. Here, my patient did not have any hoarseness or nasality. That's a good thing. Then we observe the soft palate movement. So here you observe the palatal arch for symmetry and ask the patient to say ah and see the soft palate closes of the nasopharynx. So here, my patient had good symmetry of palatal movement. Then we evaluate the gag reflex. We take the spoon or uh, tongue depressor and go back and check the gag reflex. We touch the palatal arch with the tongue depressor and see if the patient gags. So for my patient, the gag was very weak, and I had to go a little deeper to elicit the gag. So that was a good thing because some sensation is better than nothing. And then I tested the facial nerve. So basically, you ask patient to do different facial expression like smile, puff your cheeks, pucker, frown, and just see how the movement of the facial muscles are. So here he had paresis on the right side of the face because of the hemiparesis. During smile, there's a deviation, and the tongue is deviated to the right, and but was able to puff his cheeks. Then I did a bedside swallow assessment. So bedside swallow assessment, I asked KM to do a dry swallow. So now with dry swallow, he was not able to understand what I was asking him to do. So what I did was I just dipped my spoon in just water and just there was like just wet spoon and just stimulated the tongue and just asked him to swallow. He had good oral movement, so he tried to move his mouth, but there was no swallow initiation or hyolaryngeal elevation. So because there was no swallow initiation, we didn't do any bolus trial because we didn't want to risk aspiration. For therapy, we started with thermal stimulation. So what I typically use is I use a oral swab. I don't have it right now on me. We use an oral swab. We dip it in ice water, cold ice chilled water, and we stimulate the fossicular pillars. So thermal stimulation is a technique that uses cold and tactile stimulation to help with the dysphagia swallow. So the thermal stimulation increases the sensation and stimulation of the oral cavity, which helps the person to swallow faster. So basically, here, so uh, we can elicit the gag also. It's a good thing that if the patient gags a little bit. So also you can there are studies which has shown that there are functional cortical changes elicited by the oral sensory stimulation, and this helps us to understand the cortical plasticity of sensory swallow areas, thus helping with therapy as well as research. So after that, along with the cold stimulation, because the patient was not swallowing, uh, initiating a swallow, we did more of exercises. So we did trunk strengthening exercises. So here what we did was we with the depressor with the tip of the tongue and push it up. So we did this. Hope you can see. So we are pushing the tongue, tip of the tongue, and asking and pushing up. Then we go back a little bit and ask the patient to push the tongue up. Very simple. Then we say a forced ka. So eliciting the movement of the back of the tongue. Ka. You can also hold the tip of the tongue. Ka. So here I had to hold the tip because he was just able to vocalize ah. So when I did this, he was able to say ka a little better. Ka. Ka. Then we swipe the tip of the tongue from front to back along the loop. So we start with outside and go back as much as you can. Because he had aphasia, I had to like demonstrate him and spend some more time with him. Then is lateralizing from the tongue from corner of the mouth. So go. Then we worked on the tongue range of motion. So we stick the tongue out as far as possible, and then pull the tongue back in the mouth as far as possible. So we do and hold. So we are not doing very fast. We don't go. So we take it out. Ah. So you can determine how long you want the patient to hold it. Then we open the mouth and we put it and hold the stretch. So we do ask the patient to open the mouth as much as possible and then stretch it out. Then we also worked on lip range of motion because of the one-sided lip picnic. So we do smile, hold, and use a mirror. So doing these exercises in front of a mirror helps a lot. They can see and they can imitate better. Then you can pucker and hold. Then you open your jaw wide and smile. Then we do the pitch glide where you ask the patient to say E. So this came much later for my patient because he was not able to vocalize. But because he's a young patient of 50 years only, his progress was happening pretty quickly. So in a week, he was able to at least uh, imitate the vowels like A, E, U. So then that's when we started with the effortful pitch glide. So we go lower. E. So for everybody, this is not very easy. So sometimes I break it down to steps. So we go. I just start with two pitches, one lower and one higher. At least we get the vocal cord stretch. So go. E. When they have the break, it's easy for them to understand. So now you will have to be a judge how your patient is handling it and how your patient is doing it. Then we do the yawn. So basically, in the yawn, you ask them you yawn and you get a big stretch and hold that position. So basically, this exercise is to increase the strength of the back of the tongue and throat muscle. So we go tongue back and you're holding that position. Okay. And the last exercise that I should do is jaw thrust. So basically, we are moving the lower jaw a little forward and holding it. So your lower teeth should be in front of your upper teeth. So you go. Now you have to also see that a patient has any jaw problem, any TMJ issues, or any jaw replacement because you have to be a little cautious in performing those exercises. Then, while doing the cold stimulation, uh, his swallow started getting better in like 3 weeks or so. So then we did a because he's a young patient, there was very quick and good progress, and the medullary the region was not affected. It was MC and PCA. So it was his swallow functions were quite better and was coming out very faster. So we started with a blue dye test. So here, what I did was I just took a blue dye, like food coloring. I just mixed it in little water and just gave him as a dry swallow, just to see whether we have any blue dye in the secretions. Because if it's in the secretions, it means that the patient has aspirated his saliva. Now you have to understand that this is not a gold standard test. Okay, there are a lot of false negatives, so we don't follow it blindly at all. It is just a test because at home setting it's easier or where instrumental assessment is not possible. It's just one of the ways to assess it, but it is not a gold standard test and it has a lot of flaws. So use it very cautiously. He passed the blue dye test very well. So we continued with bedside swallow assessment. First, I started with 3 ml very little water and see his swallow response. And then 5, and then I did puree 3 ml and 5 ml again. He did very well. So I sent him for a modified barium swallow, in which it was the therapist saw the evaluator saw that we had reduced pharyngeal contraction and reduced hyolaryngeal elevation. He had moderate pharyngeal residue with puree, but it could be cleared with multiple swallows. Liquid, it went to the vocal cords, but it was cleared with cough. His cough reflex was intact, and puree was there was this residue and little bit going into the towards the vocal cords, but not really aspirating or penetrating. So we started with dysphagia therapy. So here we started with Shakir. Even though he had a tracheostomy tube, he was able to do it very well. So we started with isokinetic Shakir. So with Shakir, we are asking the patient to lay flat on the bed at a steady surface and asking the patient to lift his head up and looking at this foot. Okay, so we started with dynamic. So in dynamic isokinetic Shakir, we ask the patient to go up, look at the fit, and go down. So we do. So ideally, we are supposed to do 30 repetitions. It was not possible for him to do 30 repetitions. We started with 10 repetitions with 2 minutes break, and we built up the stamina. Eventually, he was able to do 30 repetitions with 2 minutes break. And after a couple of after a couple of days, we started with isometric or static Shakir. So basically, here what we do is we ask the patient to lift up, just like in the video, but keep looking at his feet. So in dynamic, we are going up and down. Here we hold the position for some time. Again, check for cervical injuries and talk to the doctor whether you can do that or not. So we started with 15 seconds with 2 minutes break, but eventually we reached 60 seconds with 2 minutes break. Then we started with effortful swallow. So again, everything was happening very simultaneously. Here for therapy purpose, I'm separating it for you. But as soon as the swallow started with wet spoon or with after the cold stimulation, I would encourage the patient to swallow hard. So here, like I would ask him to close his lips tight and pretend that he's swallowing a pill or a grape or a ball of rice without chewing it, like a hard swallow. And I would ask him to feel here. Once that got better, I started with lollipops. So lollipops gives the flavor but doesn't really create a bolus. So the sweet flavor, or sometimes I even use like just lemon juice, uh, dipped spoon, and just like give him a taste because it's sour. So sour and cold stimulates swallow better, quicker. Uh, so swallowing just becomes easier. So I would ask him to do an effortful swallow during therapy. Then we would also do Masako maneuver as soon as he started doing swallowing. This was difficult, but eventually he got there. Where we hold the tongue in between our teeth and we swallow. The tongue doesn't slip back. So doing any of these swallow exercises is very difficult if you ask the patient to swallow constantly. So in between, like after every trial, I would give him like a wet spoon or a lollipop, and so that the saliva is created and it's easier for the patient to swallow. We did EMST, working on his pharyngeal muscle contraction as well as lung strength. And then eventually, after the MBS, we worked 1 week with these exercises, and then I started with like simple, smooth puree. I would just dip the puree in the spoon and give it to him, and request and get him to swallow multiple times. So he's constantly swallowing, and so basically we know that the exercise itself, swallow itself, is going to improve his swallowing. So we build up on that. After 9 weeks, KM demonstrated good cough strength. He was able to cough out his secretions very well. So he got decannulated in 9 weeks, which was amazing. His swallow function slowly improved. Post decannulation, we start bedside swallow assessment was done with soft diet, uh, and he had good mastication. And then once he was back home, we sent him for we did some more trials of different food and improved, and we did a modified again, and we made sure, and it said that there was no aspiration or penetration with liquids, puree, and solids. So it was a hooray for us. But we instructed him that he has to have slow and average size bites, like not too big, not too small. uh, pills, one pill at a time. Or initially we were like, just crush the pill and have it. Uh, and once cough was observed, discontinued for some time, and multiple swallows. Right. So you have to understand that everything is happening simultaneously. It's not like I work on dysphagia first, then on speech language. So while we were doing dysphagia also, we were working on vowel imitation. So just imitating simple vowels like a, e, u. But along with that, simultaneously, I started with copying the tunes, like just la 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 la. I would sing, and I would encourage the family to sing with him or for him versus having a recorder. Like he loved music, he loved listening to songs, so he can definitely listen to music, but that is not therapeutic. So for therapy, I encourage, and because he was a young patient with young kids, he had a lot of good support system. His parents were not that old, so they used to participate. A wife was working but managed to spend time with him. The kids were old enough to understand what I wanted them to do and spend time with him. And after 2 months, they had the school vacation, so they had like two months of undivided attention for their father, and they did a very good job. I think they did a better job than bigger change than I did probably. So they would sing to him, and then simple nursery rhymes. And he was a English speaking person, so he knew all the nursery rhymes. A very involved father, so he knew the kids' poetries and everything. So that helped a lot. Along with that, we started with numbers. So starting with like automatic speech items like numbers, alphabets, days of the week, months of the year, name of the family. And also I encouraged using writing. So we would have like a book where we would like write down all of them, and he would look and he would have to say. So we are working on reading as well as write as well as speaking. Also simultaneously, I forgot to mention here, but I also started with his writing with left hand. So I would just ask him to draw straight lines, planting lines, different, like, how pre-writing skills we improve. Because he's never written from a left hand. He's a right-handed person who's always written. So it was to start with, at least to, start with his writing skills. Uh, Along with them, then his again he started showing good progress, and in like around 20 weeks, we started with naming. So he could come up with names. He randomly started coming up with family members' names. Daughter before wife, obviously, but the kid's name was coming up very fast. He was able to say his name. So then we started with confrontational naming. So basically, confrontational naming is we showed him either an object or a picture. So we would start with small things like first thing we would start with family members' names or simple things that he needs like a glass, water, food, fan, light. You show him the picture, show him the object, and explain and try to get him to say the name. So initially, we would ask him, "What is this?" And then this is the cue hierarchy that I follow, and I use it for all my sessions. So basically, first, if I'm doing a cue hierarchy, if I say, "What is this?" Okay, so it's a spoon. So it's a spoon. So he's not able to say it. Say, we eat with it. If I'm not getting it, like I said, I'm using writing as well as speech simultaneously. So I would write the written cue of S. If I'm not, then I would start writing S, P. Oh, I'm writing it in front of him. Then I'll write the complete word, spoon. If he's not able to say the name still, I would give him the clue of the first sound or a syllable. So we go spoo, or you can start with just then go poo. And if not, then just say spoon, and he has to model it out. Then slowly, uh, we improve that part, and then responsive naming. This comes much later with him. I'm doing this now. So here it is like what am I describing? So like I can say it's a fruit that is yellow in color and monkeys love it, or a yellow fruit that we peel and eat, or just describe it like. Where do you make a sandcastle? Beach. A hot beverage that we typically drink in the morning with, and it goes great with biscuits, tea or coffee. So I'm at the responsive naming level now with him. Then we're also doing this divergent naming. So basically category naming. I give him a category and he has to try and say the names of the in the particular category. Now again, here what I start with is now we have a phone and iPad. So finding pictures on Google is very easy. We don't have to have all of them on yourself. So I use a tablet usually, and so if I'm doing category of names of fruits, so he would typically name apple, banana, mango very easily. But then beyond that, sometimes it used to become difficult. So I would take out a picture of a watermelon and show it to him. If he was not able to say watermelon, I would use the Q hierarchy and get the word out. So similarly, here I'm working on speech, reading, as well as picture naming. Then we came to conversion naming. Here I started with using pictures. So I would show him three pictures of dog, cat, and a horse and ask him what they are. Again, using Q hierarchy, I would get to the answer of animal. Then at this stage, I'm able to do this with only written cue. I don't have to show him pictures. So his reading has improved quite a bit. So I would just write dog, cat, and horse and find categories. So now giving homeworks have become much more easier for me. Now in sentence formation, we started off with just him um uh, repeating the phrases as a drill once his naming came up. Now he had several UTIs for some reason, so he was on catheter and diaper for a long time. He just got his catheter was removed just like a month back, I think. So anyway, so some of the smaller drills I started with phrases: change diaper, give food. Then I started with the longer sentences with simple with I want water, turn on fan. Then longer ones like my hand is paining. So now he's not able, he would like his daughter's name is Inayat. And it's not a real name, but it's not her real name, but he would just like, he would say, Inayat, come, play. So I'm encouraging him to come and say, Inayat, come and play with me. So longer sentence, correct sentence, grammatically correct sentence. Then we are working on sentence formation. So now we are currently on sentence formation. So here, very slowly, we are showing a picture to the patient. Like we choose a picture and we name it. So, like for example, if I'm showing him a picture of a spoon, so I would encourage him to get spoon. So now to say spoon, I would have to give him the cue hierarchy again. We get to spoon. Now the question would be, good. Now how do we use it in a sentence? So I eat a spoon. I eat with a spoon. So here I'm trying to club a word with the noun. Like for example, if I go phone, I want my phone. Or cat. I have a cat. I have a cat at home. And so on and so forth. Now, picture description from a picture card. Okay. So here is an example. I would show a picture of a girl drinking milk. So KM's typical response would be girl, because that's the main focus of the picture. So what I would do is I would acknowledge him, like yes, that's a girl, and this is a part of constrained induced language therapy, where here in constrained language induced therapy, we focus on use. It's a forced use. Only speaking is allowed. Okay. So you can't have now I've started with this. So now we don't use compensation. So no compensations, no gestures, no writing, no ASE. And the family has to practice this 2 to 4 hours a day. So obviously, doing complete constraint induced language therapy is not possible. So we do a modified one, but at in the session we are able to do that. So here he would just say girl, and I would encourage him, don't no pointing, talk. What is the girl doing? So KM would say, girl, drink, girl, or if I can't get drink, then I'm trying to cue him with a phonemic cue, and I'm not using writing right now. So drink. So we go like, yes, the girl is drinking. So what is the girl drinking? Milk. Then I would start with modeling out with girl is drinking milk. And we have to encourage him to that. You have to say this and do not know gestures. Now say it in a complete sentence. We can give him cue to focus only on speaking and give verbal models. So this is the principle of constraint induced language therapy. Now this is the response celebration training that we use RET. So here what happens is we can use uh, pictures as well as the little cues. So here we are like asking the patient more. So I have not really used this with him because it was not very successful. He needed a lot of phonemic cues. So here I would again show him the picture, and he would go like girl, and we would go to get to girl and milk or girl and drink. Then get him to correct the sentence like the girl is drinking milk. So again a WH question. You use a WH question to elaborate on what you're seeing or what is said. So what is the girl drinking from? So you acknowledge it. So he will just say glass. He will not say girl is drinking milk from the glass. Too long a sentence. So here I would complete the sentence and I would say, yes, she is drinking from a glass. And then ask him to repeat it. Now with KM, he's not reached that long sentence level. So I've not started using this yet. But when I want him to elaborate, or when I want him to increase the length of utterances, this is where I'll be going. And again, this is another. So that is this is RET with visual clues. Now we go with RET with verbal clues. So in this, we are elaborating our sentences with more questions and steps. So here, no visual clues are given. So I'm not using uh, the right method of response elaboration training. I do cheat and I use some pictures to help name him. So, like for example, he used to make tea every morning for his wife and himself. So that is something that he wants to do soon. He wants to make tea and breakfast for everybody. So I started with like steps to make tea. Now when I asked them to steps to make tea, first I started with what do you need to make tea. So like make a list of uh, tea leaves, milk, water, sugar. So here I would write them down so that his reading had improved quite a bit. So I would write them down, and so that he gets those clues are there. In RET or with auditory cues, you don't use any visual. So here I'm cheating. I'm doing a modified one. So we start with like things. Then I would start with steps. what would you do first? So he would say water. So then I would, with RET, you're asking questions. What are you doing with the water? You're boiling the water. Okay. What do you do after you boil the water? So you're helping him make those steps. We put ginger. What do you put after ginger? You put tea leaves. So also, I'm giving him enough time to listen, process, and talk. I am not in a hurry. I have to give him enough time to process what he's saying, what he's doing. Sometimes I also use a picture. So I will just show him a picture of water boiling. पानी को क्या करना पड़ेगा? And with phones and tablets, you get so many nice GIFs. So you can use them to get a moving picture, and it is more involved and more fun. It's not too boring for them. And then, like, for example, if he's not able to come with sugar, so I would say that what do we use to make the tea sweet? So jaggery or sugar or whatever. And then I write down the step. I write down the steps and then let him read and process and make a complete sentence. And then use a lot of auditory as well as visual clues to prompt him to make a proper sentence and give step by step instructions about how to go about it. Right. Right. I think that's it for from my side. I think I went very fast thinking that I had a lot to cover, but I think I did okay.
It was actually quite wonderful because you demonstrated quite a lot of quite a few techniques actually for dysphagia as well as for language therapy. So that was indeed great because you do it as a practitioner, but getting validated from a colleague it does feel great. And like you were saying, because of the discussion, because of this talk, you're separating things out, but all of this happens pretty much
Simultaneously.
simultaneously. Um, there is nothing in the chat box. I would request if anybody wants to, request her to demonstrate any technique that she has. You want a repetition, please put it in the chat box or unmute yourself. If you have any reference, any anecdote that you want to put forth, please do that. We
Or
have the
anything that I can do for him so that because nobody's perfect. So yeah, I need help over here too. If I can do anything to make his speech, he's 50 years. So he has to go back to his work, to his children.
to his life essentially. Like
Absolutely.
he's looking forward to definitely going back to his life. I would request you that if you have something more and some more information on you were telling me about you were discussing about the cortical reorganization due to thermal
Simulation.
stimulation. Uh, can you, matlab, apart from the case, can you just talk a little more about it for the benefit of everybody attending over here?
Um, like
Just
what
the neural part just the neural part of it as a practice. We definitely do it. All of us, we definitely do it because you mentioned that there has been studies. If you could focus a little more and sort of enlighten us about it.
So the study that I read was, so basically they were using it and to see, and they were doing an fMRI,
Okay.
and they were observing the changes that are having during the cold stimulation.
Okay.
And what they found was there was there was the temporary cortical changes were happening while they were doing it because it's cold and it's the sensory stimulation increases.
Right.
So, uh, so that's why the cortical plasticity of the sensory swallowing areas, they showed us short term changes in that.
Okay.
So when that cold stimulation was happening, the patient was able to swallow faster. The duration, the initiation was the time had reduced,
Hmm.
because of which the elicitation was better
Hmm.
for the swallow. And so we can, as we are doing it, The patient swallowing, and that muscle memory is coming back.
Correct. Because in this particular patient, you were saying that initially there was no swallow initiation when you were
Yes,
beginning. To
yes.
start off, there was no swallow
No,
initiation.
and even for gag, I had to go deep down. Like
Yeah,
I could go deep down because he had no gag.
absolutely. Okay. So there is one comment that says, can the next session be about practical demonstration on patient, especially related to swallowing in its rehabilitation? I think it will be difficult for a speaker to get the patient here, but if it can be done through videos, definitely speakers can be requested
So
to do
actually,
that.
they have amazing videos online itself.
Yes,
I mean, I can quickly Google and find out. I mean, like especially if I'm doing online therapy, it's very difficult to show patient while I'm laying
demonstrate.
down and explain. Yeah. So
Correct.
I use YouTube a lot for online patients. Let me just, I mean, because I've never thought about it.
I think for both the Masako as well as the Shaker one, it is better to have a demonstration like that as well for the patient, right?
So see, the problem with Shakir is I have to lay down and show them.
Yes, yes, that's
So,
what
that, so,
that's what I was getting at. Yes,
so that's because see, rest all I can do it. Like I demonstrated here itself, Masako as well as
yes,
everything. Like
correct,
but Shakir becomes so difficult because I have to lay down explain. And
correct.
so I have used my daughter for that also. So if I have to explain, I have used if I'm home, I've used her. So but then every time it's not possible. So MedBridge has good YouTube videos of all these exercises. So
Okay.
if you Google Shakir, I'll just share my page and I'll show you. So like for example, this is the YouTube of Shakir.
No, we still can't see you. Now this is now it's
So
clear.
here and best part about they have also explained why they're doing this exercise.
Mm-hmm.
So this is the video that's there. Like
Hmm.
you can all see it.
Correct.
There's an audio to it also if you want. But basically, they're explaining why we are doing and how
Yeah.
we are doing it. So
Correct.
similarly we have for like Masako maneuver also you'll have. I mean, I demonstrated the Masako maneuver. You're holding the tongue and you're doing it. So again, MedBridge has it. They've made
Correct.
amazing videos. But again, we have to study and learn the physiology of swallowing, and we have to learn why we are doing this also,
Correct.
and we have to know why so it's easy for us to explain and easy for us to know what is happening.
So that is the reason the counseling and the way you put it to the patient and the family matters the most, because this is coming from a discussion that was making rounds in several groups, that how different professionals are definitely stepping on our toes as well. So when you spoken about the Masako, I said please go ahead and as an SLP do speak about it on a public platform, because there are definitely other professionals too who do this as an exercise basis. But how you are able to connect it to your sensory swallow therapy, how you are able to take it forward through your actual swallow therapy, the stimulation, the swallowing, it does make a lot of difference, because this is available today. This is available everywhere.
Yeah, everywhere, correct. And also, like, we also have to advocate that why we are doing it. Like,
Absolutely.
for example, you can't just tell the patient कि ये करो. If you
Huh,
explain to them हम क्यों कर रहे हैं, what difference does it make? Like, even for a pitch glide, I will tell them why I'm doing it.
correct.
Because if I am not convinced, then how will the patient get convinced in doing silly things? And trust me, our speech exercises are very embarrassing. They say. He's like, "Ka bolna?" He's like, my neighbor will think I'm mad.
No, so the point is then what happens is, हाँ वो speech therapist तो आके इतना ही करके जाते हैं. So the moment you counsel and you give the physiological basis of all these exercises, the moment you counsel, you give the physiological basis of these exercises, you're convincing, because see, the initial period that you described was a very rough patch with for the patient, for the family. They don't know the outcome. They don't know what kind of disability they are sort of looking at, what is the permanent damage they are looking at. And you're working through that, and you're there with the patient, 3 months later down the line. For that, there had to be a lot of trust that was built, right? That
Absolutely.
what am I doing? What am I looking at? If this is where I am now, 3 months down the line, what am I looking at? What kind of even recovery, the kind of hope that we as rehabilitation professionals we are able to offer, and thereby we firmly make it quite clear what our position is and what we are capable of helping them with.
Absolutely, absolutely. And also we have to realize that we touch two things of a patient's life, which is so important. Like everybody wants to communicate,
Correct.
everybody wants to eat.
Yes.
We
Yes.
have to understand that everything has to be done, and it's all hand to hand, it's all related. But we have to put in that effort also to convince the patient that you have to do it more frequently.
Hmm. It
And
is
you have
for
to know
your
why.
benefit.
And you can't just use a chintak method, or you can't just use a head turn method randomly and just do it. You have to convince yourself first, okay, why am I doing this particular thing?
For this particular patient, at this
Yeah,
particular stage of therapy, everything, there is
everything. Yeah,
factors.
exactly.
So if we are vocal about it, if we are voicing it out while we are doing it, so the patient also understands that, okay, so things I was doing a month ago, see, it's not being repeated now. I was not able to cough a month ago and now it has come, I'm able to do that now. I was not able to initiate a swallow. Now I'm able to do that right now.
And also you have to keep studying. Like, you have to keep
Yeah.
reading. Like for
Yes.
example, EMST. I got the opportunity to work with EMST while I was in US. I
Okay.
got lucky. But here, like I'm telling all my therapist friends, try EMST because it helps with the lung strength. It helps with swallowing. It's a very it's very expensive, but luckily it is available now in India.
Okay.
So I
Okay.
mean, it's a new thing, but it's helping.
Correct. Correct. So you have to keep moving ahead, right? Because everything is evolving. I was reading about providing therapy, like you said, when you were online and when you could not go. I was reading about augmented reality. How instead of being there in person for patients who have chronic disabilities, who have a chronic pain, who cannot keep coming to you, if through an app, a gamified version of the app, like you have the fitness apps, you have rewards, and that you have reached XYZ like a game, you have augmented reality where, like, you showed the YouTube video. There is a person at the other end of the app as well, but essentially there is a lot of demonstration going on where the patient is imitating. So the point there, the discussion and the conclusion was there are a lot of times you do need hand holding, and you also need to be personally present to ensure correct positioning. You cannot expect the patient to position themselves correctly and get the correct bit of, what we want to be.
Everything. Yeah, yeah. And also it changes like for example, the repetitions or the way you're doing it, like you said,
The
positioning
way you
definitely.
talk, the way you talk.
No, but every patient is different. We know that.
Correct.
Like
Absolutely.
two patients with the same area affected will exhibit two different symptoms or will progress in a different way.
Correct.
Now, tactus therapy has come up with so many apps,
Correct.
but unfortunately, we can't use them all with every patient. I can't do online therapy with a lot of my older generation patients.
Yeah, yeah,
They don't like
absolutely.
it. They don't like
They
it.
don't like it. They don't like it. Because it is like, at least if you come, I get to talk to you as another human who is present, who is willing to interact with me, talk to me.
But also, what
Okay.
because I work with more adults and children, it's like they go like, आप बहुत छोटे दिखते हो, ठीक से दिखता नहीं है.
Okay. Okay. Yes.
Yeah,
And
but also the thing is, but then with the younger patients, and now unfortunately we see so many young strokes.
yeah,
They don't have to write; they have to type.
correct.
So
Absolutely.
so for them actually for so some of my patients they do hybrid. They come online, they come to the clinic. So here
Yes.
what happens is when they're coming to the clinic, we're working on writing and speech. When they're
Correct.
coming, we are doing online, they're doing typing because nobody
Absolutely.
writes anymore.
Yeah, that is true. That is true. That is true. That is, in an evolutionary form of way that is changing our cortical representation also, because young children, they are not used to writing out a half an hour or a 2 hour papers because they switch to typing easily. So these muscles are changing. The
Changing, absolutely.
cortical representation of these muscles are changing. So I think there is, okay, so there was a thank you from Nikki. Thank you for the YouTube reference. That was very good. We need to understand how best to represent it to our patients so that, through every patient, through every patient, we are advocating as well. I think so. Nowadays, I think that has always been there. So I don't think there are any more comments.
Questions. Yeah.
So yes, I think if there is anything more to be discussed, people can get in touch with you directly. We are in closed groups. They can get in touch with me. I can put you.
Absolutely.
That is not an issue at all. So thank you so much. It was a wonderful description and discussion as well. It was really nice. It was
It was my pleasure.
Thank you. And this is something very small for you as a token of love and
Thank you
appreciation.
so much. Thank you so
Doing
much.
this and including us on your Sunday morning as well. So thank you so much. I thank the entire audience for being here on a Sunday morning and post festivities. We hope to meet soon again with more case discussions. Again, I request the audience, if you want to discuss a case, you want to share your joy and pride, do come ahead and we can set up something like this that we did today. Thank you, Moumita, so much for
Thank you. Thank you so
doing
much.
this. So there are people saying we are going to look forward for more discussion on it. So like,
Absolutely, you're doing amazing job here, and this
thank
is
you.
great. I mean, thank you for making me a part of it.
It was absolutely, my pleasure. So, you accepted this and, we could go on to the adult bit of it. So now I think there'll be more of adult case discussions as well along with pediatrics. So I hope you also enjoyed and we managed to wrap up on time for people to go back for their shopping and lunches.
All right. Thank you so much. Thank you, everyone.
Thank you. See you.
Bye.
We'll wrap today. Bye bye. Bye
Bye.
bye.